that big, marvelous machine that is your mind. Can you tell the difference between reality and imagination? I'm sure you can. By now you've probably figured out what the real world looks like, how it feels, how it behaves, even how it smells and tastes. But still, when you're experiencing something together with other people, like sharing a meal at a restaurant or listening to music, there's a good chance that their experience is different from yours. Why is that? If they're having a different experience from you, are you really experiencing reality? Or are you experiencing your reality?
But what is reality? Asked the gnome-like man. He gestured to the tall banks of buildings that loomed around Central Park, with windows glowing like the fire caves of a city of Cro-Magnon people. All is illusion, all is a dream. I am your vision as you are mine. That's an excerpt from a short story about a man named Dan. Dan finds a pair of glasses, places them on, and is transported to a vivid dream world right from where he stands. The really, really interesting thing about this is it was written by Stanley Weinbaum 84 years ago. And it's quite a vivid prediction of what we now would call virtual reality. So I'm here today as an intensive care nurse, a curious nerd, and a dad of kids that are growing up with this technology as the norm. I'm really not intent to stop looking for better solutions for the problems that plague our intensive care patients. The persistent suffering and pain that we just haven't found a good solution for yet. So what is VR? Virtual reality, in its simplest essence, is a computer-generated 3D environment in which people can explore and interact with the program that's on the screen. There's been attempts at commercial production of VR systems for wide markets since the 1950s with the Sensorama, and pretty much one or two every decade, right up until the second worst selling Nintendo platform of all time, the Virtual Boy. I mean, those red graphics, they would have just been so amazing. So we're not going to talk about games today. And we're not going to talk about training, although it's interesting. There is definitely an explosion of virtual reality training solutions, healthcare starting to take the market. Instead, we're going to look at clinical therapeutic applications for virtual reality. Today, VR encompasses a whole range of stuff, from simple 360-degree video that we can use with cardboard headsets on our own phones, right through to the system you saw me wearing, which constitutes a headset with some motion tracking, some haptic sensor feedback handsets, and detached motion trackers. Virtual reality, like all new technologies, poses the problem of what to adopt it for, when, and what's the risk. So I think we need to ask one more question than that, though, and it comes back to we're not keeping in pace with technology innovation. We need to ask, what have we not been able to find a satisfactory solution for in our workplace? And could technology offer an opportunity for that? So in terms of safety profile of virtual reality, in the clinical trials so far, the adverse events reported are headaches, nausea, and dizziness. Most of these seem to be able to be mitigated by repeated use of the virtual reality system or using a higher quality, lower latency product so you don't get that stuttering effect. There are a few people, though, that tend to get very bad vertigo from it, so that's just a general caution. So overall, and this is how technologies are often marketed, the tool itself is pretty safe. But does that mean we're ready to apply it for different clinical applications? So to help answer that question, I've sort of done a bit of legwork and done some literature review on the broader clinical literature around virtual reality as a therapeutic tool. At the moment, it neatly divides up into pretty much 3 key categories: anxiety and post-traumatic stress therapy, neuro rehabilitation, and acute pain management. How we're going to dissect these over the next few minutes is just look at a short vignette for each of them and look at how virtual reality therapy might work for my patients. So I've drawn for mine. Hopefully it's close enough that you can extrapolate it to yours. So first we're going to talk about Sarah. So Sarah is a 42-year-old lady who had a 10-day admission to intensive care for an influenza pneumonitis about 2 months ago. We're seeing Sarah today, and we've seen her a couple of times, in our outpatient post-ICU follow-up clinic. Sarah doesn't remember much at all about her intensive care stay. She's still quite distressed by it and has a lot of fragmented memories about it. So we've offered to Sarah, with great reassurance, to provide her a bit of a tour and an orientation back to the intensive care environment, and hopefully go through any questions that she has to help with that maybe faulty sense-making cycle. She's really reluctant to do that because of the fear of sort of trauma from it, and also from the worry that she might see other patients or families and and that might exacerbate her worries. So I think this is definitely an area that the potential for us to virtually take Sarah back into the intensive care in a controlled fashion from her seat within the outpatient follow-up clinic offers some real promise. So in the literature, there's this really cool thing. I mean, it's so cool. It's got binary code, there's smoke, and there's guns and stuff. This is actually a program that was developed by Skip Rizzo for the US military, and was used. It's a PTSD psychological exposure therapy program that was used for soldiers returning from primarily Afghanistan who had had refractory illness with their post-traumatic stress disorder after receiving traditional prolonged exposure therapy, the traditional one being the imaginal exposure therapy. Bravemind offered a solution of being able to actually customise down to a whole multitude of different mission types and layered textures such as ambient sounds, different personnel in or out of the scenarios, and times of day. So able to reconstruct some of the textures that a lot of these soldiers weren't actually able to remember or imagine. I think there is obviously for me some translation there for Sarah. Is it ready to go yet? I'm a little unsure. I don't think we could say that it's proven therapy. It's a big leap between the spaces, and this has been done with a lot of rigour from a psychological point of view. I think there's definitely promise in wrapping a research ethics proposal around that, engaging psychology in our multidisciplinary team, and looking at this as a viable option. Neuro Rehab. So there's not much science to guide neuro rehab, none that I could find for intensive care patients. We're extrapolating largely from the majority of work in this is around stroke patients. There's not even much I could find around traumatic brain injury. The best research source on neuro rehab is from a Cochrane review in 2017 on stroke. So I'm going to try it out on Alphonse. Alphonse is a 62-year-old guy. He's 21 days in intensive care with critical care acquired weakness after a severe septic illness. So Alphonse is having twice daily physio and occupational therapy during the week, because that's when we have staff. He gets once a day on the weekends. And he's requiring a lot of motivation and cajoling to do it. It's hard work for him, and he's just not that keen to do it, but he will engage if he's got someone there working him through. So what we know from the stroke research on this is that VR alone as a standalone therapy demonstrated pretty much no benefit to motor function scores. The interesting thing was there was demonstrated in a range of about 10 studies, a demonstrated benefit in improving performance of activities of daily living when VR was added to traditional rehabilitation therapies. It seemed through the majority of those papers that the effect was probably due to increased time in therapy. This is a real problem for us in a lot of ICUs, that we don't have full day coverage, don't have the ability to do multiple points of therapy. So I think there's definitely a potential offering there for us. I can see Alphonse using one of those custom apps or one of those bubble popping apps. One of the ones they use for shoulder mobility is putting on the headset, the handset, and doing bubble popping to encourage moving. One of the big things about this in this population that was also reported in a couple of papers was it gave them improved sense of self and perceived quality of life. And one of the things that was attributed to in some of the qualitative data from this was that they were able to re-engage with things that they liked doing from their bed space. So Alphonse is looking pretty happy right now. Again, it's certainly not a proven therapy. It's a big extrapolation from stroke to critical care acquired weakness. But for anyone who's keen to pick that up and run with it as a research topic, giddy up. The third, and what I would say by far and away the most convincing body of literature of clinical VR use is around pain. So we're going to have a look at Jamie. Jamie's a 32-year-old guy in our ICU who's been admitted after a really complex abdominal surgery. Jamie's requiring frequent vac dressing changes, and it causes him excruciating pain, needing morphine and often benzos to tolerate the dressings. So the literature around pain is one of the big things is the diversity of it. So there's been positive results reported in the use of VR as either an adjunct therapy or even a medication-sparing therapy for areas such as operative procedural pain, oncological pain, labour and delivery, emergency procedures such as joint reductions, and by an absolute landslide, burns. Burns treatment, like Jamie's recurring treatments, carries an interesting dilemma with pain, because one of the burdens of the frequency of the procedures that induce the pain, is that there's a lot of time spent thinking about pain and anxiety about that next intervention. The pioneers in the research around this are Hunter Hoffman and David Patterson. So they created the Snowball App, which was used first in the US military and then into a whole range of different burn centres. And it is literally just a very simple game where you throw snowballs while wearing VR, while having burns dressings. Their landmark study in this showed a 7 times increase in efficacy of the opioid analgesia in the VR group, a 50% reduction in time spent thinking about pain, and an 80% improvement in a fairly cheeky novel measure that they included, fun during dressings. The control group had 0. So I think there's a really solid extrapolation there to our patient groups. This is starting to be explored in the UK and Europe, and I'm sure in some centres in North America, although it's actually pretty hard to find what trials are going on. I think that this is probably pretty close to being safe to call VR for pain management a proven therapy. The really added benefit here is there doesn't appear to be much money to be made by driving this agenda forward, which actually reduces my skepticism about the reporting of results. The apps used in most of these studies are everything from just your own mobile phones with 360-degree video that's currently already there on YouTube, through to just simple customizable apps for Oculus Rift and HTC Vives and the similar. So how does it propose to work for pain? The simple one is obviously distraction. There's three proposed mechanisms really. So pain requires conscious attention, so there is a distraction element to it. But digging a little bit deeper, gate control theory is the second proposed theory by which it works. That is really along the lines of noxious stimuli compete for bandwidth with non-painful stimuli, from sensory to the CNS. The third way that it's proposed to work is with intercortical modulation. And this is based on the concept that stimulus of the motor cortex can suppress perception within the sensory cortex of the brain. What does that tell us about what sort of VR we should be using or how we could apply it to pain? Well, it says probably one mode, video alone, we'll be okay. It'll provide some distraction and maybe some work around the gait control. But like analgesia, it's suggestive that probably multimodal is best. So this kind of leaves us to ask the question, are we actually ready? Is it ready for use in my population? Is it ready for use? Can you see it in some of yours? I think we've got to be careful of therapies looking for a disease. We don't want VR to become the next flavour of the day, the ECMO or Reboa of 2020. But we do need to not just go back robotically to work and accept the problems that we haven't been able to find solutions for yet. So for me, this is what my future might look like. I think with strong engagement with clinical governance and our multidisciplinary teams and shared decision-making with patients and families, it is really viable for us to offer virtual reality at the moment, straight away, when I go back and talk to my boss in our intensive care for acute pain-inducing procedures. So that kind of leaves me with the proposition that I think I am ready, and really only leaves me to ask you guys, are you? Thank you.